Good afternoon, everybody. I hope everybody is keeping well. I'd like to greet you from a warm and sunny Johannesburg. As we get started, welcome to today's webinar. It's a platform for exploring the transformative impact of mobile technology on maternal health in rural Africa. This event is more than just a discussion. It's a call to action to harness the power of innovation to overcome the unique challenges faced by expectant mothers in remote and underserved regions. Funded by the UK Foreign, Commonwealth and Development Office, this initiative, launched less than a year ago in September 2023, this is a testament of the power of collaboration. It represents a strategic partnership between Wits University and Carter partner institutions, including the University of Ibadan, aimed at fostering multi-sectoral cooperation to improve maternal health outcomes. Maternal healthcare in Africa's rural areas faces significant challenges. Inadequate healthcare infrastructure, a shortage of skilled medical personnel, and socio-cultural barriers often prevent timely access to essential services, particularly during emergencies. These challenges contribute to alarmingly high maternal mortality rates and poor health outcomes for both mothers and infants. However, there are mobile technologies that are emerging which are offering a beacon of hope. Today, we'll focus on the groundbreaking innovations that are leveraging mobile technology to improve emergency care for pregnant women in rural Africa. We will explore how mobile applications are being used to connect expectant mothers with emergency transportation and skilled obstetric care, dramatically improving response times and healthcare outcomes. These advancements are not just technological, but are also reshaping the healthcare landscape, making quality care accessible even in the most resource-limited settings. We are privileged to have Today, we are privileged to have outstanding speakers and presentations. First, we will have a live demonstration of updates to the DIMA Link app by Professor Jude Igumbo, a leading digital health advocate and developer. Following that, we are honored to welcome Professor Friday Okonofua, a distinguished expert in maternal health, who will deliver our keynote presentation on the theme of transforming maternal health through mobile innovations. And I must apologize because I was so excited to get started. I forgot to introduce myself. My name is Ines Kosana. I am a health journalist and editor based in Johannesburg. Please join us in the chat. Tell us who you are, where you're from. We would love to hear from you and keep this conversation going. Before the session begins, I'd like to outline the agenda for today's webinar and set a few ground rules. Our sessions will include the mobile app demonstration and the keynote presentation. And finally, we'll end off with a Q&A session. Please do submit your questions at any time during the webinars using the chat functions. Together, let's explore how mobile technology can revolutionize maternal healthcare and make a lasting impact in rural Africa. Through innovation and collaboration, we can ensure a brighter, healthier future for mothers and infants across the continent. Professor Jude, I'd like to hand over to you.
Thank you very much, Ina.
Prof, you are on mute.
Thanks, Ina. Good afternoon, everyone, and good morning, depending on where you are, and welcome to today's presentation. It is my pleasure and privilege to share with you, first of all, describe the DIMA Health platform for those who are joining us for the first time, to get to know what the platform really is all about and what we're hoping to achieve. And also, in today's presentation, I will also take you through why we're doing what we're doing, how we are doing it, and also demonstrate some of the resources that we have developed. I hope people can see my slides.
Yes, we can see your slides. Okay.
But before I proceed, to acknowledge again all of you for joining us, and also especially the keynote speaker. It's an honor and privilege to be in the presence of a leader on the topic. And we're hoping and looking forward to your insights in guiding the conversations that would follow. As far as the DIMA Health project is concerned, the reason why we are doing it specifically, we embarked on this project given our concern, our observation rather, of the limited access that pregnant women and women with newborns have, and the impact that it has on well-being, and of course, issue of mortality as well. And what really plagues this significantly in terms of access to health services are issues around poverty, limited infrastructure, social inequalities, and all these make response to this health issue a multi-sectorial approach or multidisciplinary approach in terms of addressing maternal mortality or maternal health outcome issues. Still of concern to us is the fragmented and inconsistent programs that hinder effective maternal health interventions across Africa, and also lack of collaboration between the various role players. We have various people working, doing their very level best in different fields and disciplines, but often in silos, and these waters down the impact of the work being done by these people, various groups in different disciplines. But if we all could come together or find ways of coming together, hopefully we would be able to support our various initiatives and together be able to do more logically. And furthermore, in terms of our mission, our goal is to contribute to reducing maternal mortality rates in sub-Saharan Africa through innovative digital solutions. So our emphasis really is not to create or push digital solutions across the continent, but rather to find digital solutions that could potentiate various other innovations that are happening across the continent. The idea behind this is that we all know the power of technology and how we are able to do more with technology, and with the recent advancements as well. We learned a lot during the COVID pandemic, how we were able to continue life mostly as a result of technology, either through learning on digital platform or being able to communicate on digital platforms. And the same way, we are hoping to leverage such technologies to tackle the problem of maternal mortality in Africa. We're also cognizant of the fact that the technology, spread of technology across the continent would also varies, where you have places where access to smartphones is widespread, and other areas where access to basic SMSs could be an issue, and places where even having a phone call to reach those that you want to connect could also be an issue. Whatever be the case, we are optimistic that there is a technology that is suitable for every location. And we are committing ourselves to working with people to find what works for different locations, and to develop such technologies to help potentiate the very innovative work that is happening across the continent. We have been working on this since September last year with the support of FCDO. And we are hoping to achieve our goals through a number of approaches. One of them is the artificial intelligence-driven research evidence translation, which takes complex knowledge and simplifies it, and also able to curate this amount of evidence that is pulled from various sources. We're also integrating that with data analysis to improve our data analytics, and we all know the value of data and decision making. We also hoping to use a platform to create a place where stakeholders can work collaboratively to find solutions that are relevant and impactful, but also brings together different knowledge and disciplines in addressing very complex issues. The role of poverty, the role of socioeconomic determinants in maternal mortality and maternal health outcomes cannot be overemphasized. And for that reason, a big part of our work also hopes to empower community, both through knowledge and also other income generation initiatives in addressing these issues. And our various solutions that we'll describe in a moment all seek to achieve this. In our journey in the last 6 to 9 months, we have also learned a lot through these kind of conversations with various stakeholders. And our emerging approach now is a co-creation and localization of partnerships for solution. And part of that has led to the development of our DIMA Academy, which I'll describe in a moment, or some of you could access on our website what we hope to achieve through that. As part of today's presentation, we are also thinking of what we call the Safe Passage program that looks at creating or scaling up the innovation that Professor Okonofor will be describing in detail in a moment. Still on that, in our last, there's a hand up. I'm not sure if the moderator could check what's going on. Still on co-creation of solution, in our last engagement or our first engagement in March, the need to move our website into a mobile application came up. And since then, we have been working to create the mobile application that I'll be describing our progress in detail in a moment. So as far as that's concerned, we have created this mobile application that I've shared a link in the chat for people to feel free to begin to download. And this also works with our last promise in our last meeting, in our last webinar, to make this public as well. On this matter, as far as the DIMA link is concerned, we have within it what we describe as research translation, which really is aimed at empowering stakeholders with easy, understandable information to inform decisions. We've also created this in multiple languages and in plain summary that anybody really can understand. We have our data analytics platform that helps to use evidence-based decision making and to also inform the development of strategies to respond effectively to real problems in society. We have our country profiles, which we are hoping to use to support the tailored interventions and comprehensive analysis across region, and also be able to have some comparative analysis that could inform the tailoring of solutions or localization of resources to where you have the greatest needs. Our innovation handbook both on our website and on the mobile application hopes to enhance knowledge sharing and adoption of effective practices, and we are appealing to potential partners and collaborators. So feel free to share innovations that we can load on the platform that creates a learning hub that stakeholders across the continent can learn from. Our stakeholder network, including those who have joined us today and many others, we are hoping to attract. It's aimed at fostering collaboration, partnerships, and sharing resources to foster impact. Our services directory is our early attempt at creating a robust catalog of service providers across the continent, starting with the 3 countries where we are currently working, where we have the various levels of care are captured on the system that users of services can easily find services closest to them using our directory. Still on that, we don't hope to end with creating just a directory, but we want a situation whereby users of those services are able to rate those services as well and review them by providing feedback after using such services closest to them, or they would have access through our system. And through all this, like I said at the beginning, we are not only hoping to create this system on a mobile application, but also hoping to extend it into other technologies that could be appropriate for various locations, including using SMS technology to trigger and initiate or receive services, or as we go on, begin to explore the possibility of having call centers to link collaborators or to link people to solutions as well. Still on the various items that we are developing, we have the discussion forum where people, such as those who have joined us in today's meeting, can start conversations and engage in discussions to find solutions, to collaborate, or to answer questions that are pressing in any particular area or across the continent. We also have a private messaging that will allow somebody working in a remote area to reach out to an expert in a different location to ask questions or get support through the private messaging options as well. The DIMA Academy, which we're hoping to use to train, to provide essential skills that we have increasingly observed to be one of the limitations of addressing maternal and child health issues, equipping people with the relevant skills from very basic issues of respect and empathy to more complex issues of dealing with clinical procedures. Most of these could be offered on a platform by qualified people and have these courses accredited by universities across the continent. So it's recognized and people are certificated accordingly. What we're also exploring, which we have started developing, is the Safe Passage Program, which will be a safe and affordable transport system that we're hoping to roll out across the continent, where pregnant women and those with newborns are able to get affordable and safe transport systems to get to health facilities and also to book appointments and navigate the various challenges of accessing health services by using the platform and other resources that we are going to integrate on the system. So in a nutshell, these are some of the key features we have added to the mobile application. And like I said, the idea really is to take most of these to also have SMS capability to initiate some of these services or receive some of these features on the mobile application. But to give expression to all these I've talked about, we require that we form collaborations. We cannot do this on our own. This project has been running for about 9 months now. And to localize it would mean that we begin to tailor some of these solutions to meet most of the existing interventions and projects that are running. We have had requests already from places where people want to use our platform to enable more collaboration, interaction, and exchange of information between a group of experts. And the same can be used in many other locations, or various other elements of the platform can be tailor-made or customized to serve various needs across the continent. And we are open to customizing this to serve needs of our other collaborators across the region. But we have prioritized Kenya, Nigeria, and South Africa because that is where we currently have funding for. But again, part of our project is to also develop a sustainability plan that will help us keep this project beyond the funding period and also be able to eventually reach out to other parts of Africa beyond where we are currently focusing on, but more importantly, be able to raise enough resources through our various sustainability measures to support the various role players on the system, from the transportation services to lay healthcare workers that we're hoping to onboard on the system and other role players as well. These may also involve getting the private sector onto the system. So in a nutshell, this is what we have done to date. And I would invite those who are interested in downloading the application to please jump on the Apple Store to download using the QR code provided there or the link that I have also added to the chat to access the mobile application. It is not yet available on Android because Google has a different quality assurance process before it is made public, separate from what Apple does. So Apple has quite stringent measures, but in terms of time to roll out, the App Store does it a lot faster than the Google Play Store. So it will be available on Google Play Store in in a couple of weeks, maybe in 2 weeks from now. This is our first attempt at creating the application. There's still a lot of work to be done. We are appealing for support and collaboration in creating something that will really work for the whole of Africa. We are not claiming to have a perfect system. There are no perfect systems from initiation. Systems take time to build. It's for the same reason that you have most of you are familiar with updating your various applications on your mobile application, on your mobile phones. And for the same reason, we'll keep building and developing this to respond to the needs of those we are hoping to benefit from the platform, which we are hoping would not just be health service users. It will include policymakers. It will include health service providers, both in the private and the public sector as well. So these are the various people that we're hoping would use this platform. And we're calling on all of you to work with us in setting it up to be responsive to the needs through customization. And we are open to collaborating with those who are interested in the system. I would have gone to demonstrate the app by opening it up, but I think that would take a little more time. So what I would do instead would be to try to play a video that describes what the app does. And I invite everybody to visit the website. Everything we have on the app is on the website, and we are also hoping to get more data to add to the website. Most of what we have also done on these platforms are mostly proof of concept. And we may not have enough data to cover the whole of Africa yet, but we are open to collaboration to pull more data, to enrich the system, to provide also information in real time. But without taking more time, I will play the video and hoping it to give a quick idea of what the app does. Sorry, I understand that you did not get the audio of the demonstration. I apologize for that. That's audio on my side. So I think what we'll do is we will add this immediately to our YouTube page, and people can revisit the YouTube page to learn more by playing the video that I've just shared. So sorry about that, but I hope it gave a bit of a snapshot of what it's about. But the same material is available on our YouTube page. Thank you. Ina, over to you.
Thank you very much, Prof. Can I please just ask that you remember to share the link in the chat for the app for those who were not able to download it, so that people can...
I'll reshare it. Thank you.
Thank you very much. I'm going to squeeze in one question before we move into the keynote speaker. We have a question here from Fodi Kamara, who asks, what kind of information or data would you need to include another country?
Thank you very much. The request we received in our first webinar in March was that we include real-time facility data, in this case, DHIS data. So if there are partners or countries who are keen to get on the platform, what we need from you is DHIS data. And if you allow me, since the app did not work, you didn't get quite good audio, I could show quickly, just in 1 minute, how that works on the system.
Okay.
But if you don't, if time doesn't permit, I will encourage people to go to our website. You get all that information from the website, and feel free to explore as needed. I'll leave it at that. Back to you, Ina.
Thanks, Prof. If we get time at the end, I'll see if we can squeeze you for 1 minute. Thank you very much.
Please, yes. Yeah, thank you.
In the meantime, I would please direct you to have a look at our Q&A box and respond to some of the queries that we have. I'm worried that we might not get through everything. Thank you. Okay, with that said, ladies and gentlemen, I would like to move on to our keynote presentation for this afternoon. I am so excited to welcome Professor Friday Okonofwa, a professor of gynecology and obstetrics. He'll be presenting to us on the topic of transforming maternal health, mobile innovations for emergency care in rural Africa. Prof, please do correct me if I am not pronouncing your name right, but we are so excited for your presentation. Please go ahead. You are on mute.
I'll give you 70% in your pronunciation of my name. Try very well. So, distinguished guests, ladies and gentlemen, it's a pleasure to be here, and I want to first of all thank the DIMA team, Professor Igumbo, for inviting me to deliver this keynote address. I will be sharing my slides from right away. Let me share my slides. Yeah. Are you seeing it?
The screen is still dark. There we go. Yes, we are seeing it now.
You're seeing it. Okay, thank you. So it's a pleasure to be here indeed, because the issue of maternal health is a major concern.
My apologies, Prof. Could you put your slides in presentation mode?
Okay, that's good. I'll do that now.
Okay, thank you very much.
Just hold on. A second. Is that okay now?
Yes, that's good.
Is it clear? I think the passion I've had over the years is to talk about maternal health, and we've done a lot of work over the several years to be able to identify what needs to be done to reduce the very high rate of maternal mortality in the African continent. I will begin with some contributory, what I will call some comments. First is why maternal health is important. As you know, it is maternal health, specifically is the health of women during pregnancy, during childbirth and the postnatal period. And specifically, it includes antenatal, intrapartum, and postnatal care. And we know that the central nature of development over the years, when the ICPD was first proposed in 1994, for the centrality of women as the centerpiece of development. And so for all of the milestones that we've had since that time till now, the improvement of mental health and women's well-being, several conferences have emerged as very important themes, both as Goal 4 of the MDG, as well as now the Goal 3A of the Sustainable Development Goals. And we know that if you want to use a single measurement to compare countries in terms of social development, maternal health is the single most important indicator. So it is that important. And, if you are comparing countries in terms of what they are doing for development, maternal health comes out top as one of the most important elements to consider. Now, taking further definition, we know that maternal health as an indicator can be assessed by the number of women who die during childbirth. Childbirth is supposed to be a pleasurable event, but unfortunately, we have women who die as a result of trying to give birth to the nurse population. Maternal mortality rate is the definition of the death of a woman while pregnant or within 42 days of termination of pregnancy, regardless of the duration and start of the pregnancy. And from any cause, even if it's a road traffic accident or occurred during pregnancy, or if it is suicide, all of these are still epitomized as maternal mortality. A maternal mortality ratio is the number of maternal deaths per 100,000. These are just broad definitions for those who may be in other disciplines, because maternal health has increasingly become an intersectoral multidisciplinary discourse. So I welcome so many of you here who I see, I may not necessarily be health providers, but are working in the domain to improve health and development in all countries. So you can see that more and more, you can see the dark areas there that represent the regions of the world with the highest rates of maternal deaths. And these are epitomized Central and West African countries. Come very closely in mind. You can see that Nigeria there, Central African Republic, we see Sudan, we see Chad. These are the countries with high rate of maternal mortality. And a few deaths around the Sahel region, concentrated in that region. And then you see one country in Asia, India, doesn't have a very high rate, but have a high number given the high population of India. So this is it. Africa is the domain, is the region with the highest rates of maternal deaths. And if you look at it again, there are almost about 300,000 deaths worldwide from maternal deaths. And Africa, out of 287,000 deaths, Africa contributes about 202,000 maternal deaths to the global figure, representing a lifetime risk of 1 in 37 pregnant women being at risk, compared to 1 in 3,400 in Europe and 1 in 1,400 in Western Pacific. So Africa is the domain, is the area where we have the high rates of maternal mortality, and also the highest rate of underdevelopment and social stagnation, as I would say. And if you go further, you see that, as shown here in terms of rates, Africa accounts for about 70% of the global rates of maternal mortality. 70%. And maternal mortality rate in sub-Saharan Africa is nearly 2.5 times above the global average. The global average is about 223 per 100,000, but Africa has an average of 545, which means that we are contributing most to this global problem. And if you look at it in terms of Africa, there are 3 world regions, African regions: West, Middle, and East Africa. West and Central Africa contributes the highest number of maternal deaths, Nigeria being number 1 in that area. And you can see the rates in Nigeria, 82,000. This is by 2020, by the way. And, Nigeria at that time, which was estimated by the WHO, 82,000 women died every year in Nigeria, which represents about 28.5%. Before 20,000, the estimate indicated that India was actually higher than us. And at that time, Nigeria contributed about 18%. But now, these days, Nigeria is contributing about 28.5. And if we do the analysis today, given the difficulties we have had in this country, it is likely that we will find that even 28.5 may be higher than we currently have. So if maternal mortality rate is to be reduced, I think emphasis must be paid to Nigeria's problems. And I thank DIMA for considering Nigeria as one of the countries where the organization is implementing this project, this very novel project of e-health with respect to maternal health. So this, again, I want to show two broad categories. We know as medical practitioners on the left, we know what I'll call the immediate causes of death, which are biomedical, postpartum hemorrhage, eclampsia, obstetric labor, G. infection. But I want to say that all of these complications on the left occur in all parts of the world. There's no single country in this world that doesn't have postpartum hemorrhage. But the challenge is that they don't die. Those countries don't die. They're able to manage those complications in ways to prevent maternal death. But if you look at the right, you see that part of the reason that women die from childbirth in Africa is because of what I call distal socioeconomic factors. This includes ignorance and illiteracy. I've underlined the word literacy there because that is very important. I'm going to talk more about that. Poverty, the fact that they are resident in rural communities, because that's where you don't have facilities. They have to travel long distances before they can seek healthcare. Harmful traditional practices, which, at the beginning in 1980s was very serious, but now it's beginning to reduce. Gender inequality. And then most importantly, I will also talk about the issue of delayed health seeking, which is much more evident in many of the African countries where that death rates occur. Again, I will talk more about how that delay impacts on death and how e-health can prevent the delay. That's the reason why we're here today. So if you look at the pathway to death, you will see that the immediate cause of death are not the obstetric complications. They are the intermediate. But the immediate cause of death is due to delay in health seeking, in women seeking health. This slide, to my mind, is the most important slide in this discussion. Because if complications occur and those complications are immediately treated, it's not likely to lead to death. It is the delay in the treatment of these health complications, the delay in receiving emergency obstetric care that eventually leads to mortality. And you can see that those delays are often due to background socioeconomic and cultural factors, apart from the fact that even the obstetric complications themselves are often due to adverse socioeconomic and cultural factors. I remember when I was doing my PhD in Sweden, and one of the things I usually teach my students about what this delay means, that in Africa, a woman has bleeding, she takes hours and to come to even leave the house, and when she leaves the house, difficulty in transportation, when she arrives in hospital, there's delay in receiving treatment, the facilities may be not there, the competencies may not be there, and so on and so forth. By contrast, when I was doing my PhD, I remember I was in the classroom, and suddenly I had a loud noise on the roof, and then I was the only African actually in that meeting, in that class. So I was poised to run out because I thought that was a disaster trying to happen. But a friend of mine from Palestine, the only guy who was next to me in terms of cultural relationship, stopped me. I said, Friday, stop, don't go. And I said, don't you know, it's a plane that landed, it's a helicopter that landed on the roof of the hospital. So I said, what is helicopter doing here? And when we now came out of the class and we were taking lunch, and he now told me, look, we saw a woman being wheeled on the top of and this man was taking on a telephone conversation, smoking a cigarette, and telling her husband back home that she's safely arrived in the hospital. And she was wheeled to a theater immediately. That was so astonishing. I never forget that episode, that a woman who had a complication at home in Sweden was called for ambulance for a help, and a helicopter arrived in the house, took her away, and brought her to the hospital. In minutes, she was ruled to the theater. By contrast, that same challenge can take hours and even days for women to receive care. So I underline the word delay. It is not the obstetric complication that cause death in Africa, but the delay in health seeking by women who experience pregnancy complications. So look at the evidence that link education with maternal death. The higher a woman's education, the lower the risk of maternal death. It's been shown by UNESCO. You can see that women without education on the left side have very high rate of maternal death. By contrast, as the level of education improves, the chances of maternal mortality will be reduced. But when you get to upper secondary compared to post-secondary education, often there's no difference. So what is important is education. Any level of education improves maternal health and reduces the risk of maternal mortality. If you look at the Lancet publication in 2024, it was published in June 2024, showing that rural communities, but where does maternal mortality occur? And you can see on the top left-hand corner, in red is people who live in rural communities. In Africa, it is shown evident that if you live in rural community, the maternal mortality rate is almost double. In Asia, a little bit of doubling. Compared to Europe and North America, maternal mortality rate in Europe and North America are not different between rural and urban area because probably the facilities there are well distributed and they have emergency services. And similarly, in Oceania and Latin America, there are high rates of mortality in rural community. If you look at the top right-hand column, education, you also see that with low education in all contexts, except Europe, except Europe, in all contexts, the lower the education, except Europe and North America, it's evident that with lower level education, women are more likely to experience maternal deaths. And again, equitable delivery of health services in Europe and North America, regardless of the circumstances, may be the reason why lower education does not necessarily increase maternal mortality. If you go to lower bottom, you see that rural education, if you look at the effect of education in rural communities, on the left-hand column, you see that regardless, even in rural community, the lower the education, the higher the chances of maternal mortality. Again, and if you look at Europe and North America, you go see that there's no difference in terms of whether or not you have education in rural communities or you do not have the education. Again, showing the equitable delivery of services response to everybody in community as being responsible for ensuring that even in rural community, lowly educated women do not die from maternal death. If you look at the situation in Africa, we see that urban residents versus education, women who are educated, who are who have low level education and reside in urban areas are less likely to die as compared to if they resided in rural communities. Again, the differences in Asia, Europe, North America in that particular respect to the availability of education and maternal health in urban communities is not as serious. But if you look at Africa and Oceania, you find that the difference is significant. So this tells you that the two main factors responding for this, which must be addressed. Somebody told me that education and rurality are very important. And if you look at this, was very depressing to me, which was a paper I read in June 2024 recently. We show that projected improvements in maternal mortality by educational levels intervention. And if you look at it, those in dark shows that if you apply education or if you do intervention-related education, you have 100% reduction in maternal mortality. But if you look at my country, in Nigeria, look at it, it's in white, meaning that regardless of education, maternal mortality is not likely to improve. That was very depressing to me. When I read it, in fact, means that even with educational, even though my great mentor, Professor Kelson Harrison, over the years, I've been talking about education as an elysia to reduce maternal death in Africa. But if you look at this publication, it shows that even with education, Nigeria as a specific country, and probably South Africa, may not experience further reduction in maternal mortality. And Ghana, too. But if you look at Central African Sahel countries and all that, we find out that there will be significant reduction in maternal mortality if education is added as an interventional component. So that is the challenge. That means that in those countries where education is not likely to play a role, other critical factors have to be addressed in a comprehensive manner. Maternal mortality is one single outcome that needs multi-sectorial improvements. Requires everything to be functioning perfectly well in the community before you can get a single reduction in maternal mortality. That's the reason why it is the centerpiece development everywhere in the world. So look at the delays. Let's talk about the delays. This is very important. I told you that three types of delay. This was a delay proposed model which was established in 1993, showing there are three types of delay. Delay number one is the delay in a woman seeking decision to seek care when she has experiencing complication at home. Delay number two is when she tries to seek care, but she has difficulty in transportation. And then delay number three is when she experiences difficulty in breathing, delay in receiving treatment when she arrives in the hospital. Delay number is a very important framework that has been used over the years to explain, why women die, circumstances that women die. They don't die from complications; they die from delays. Delay number one, delay in decision seeking care, which is often epitomized by the three factors on the left: socioeconomic factors, accessibility of facilities, and quality of care. By contrast, if you look at delay number two, which is difficulty in reaching health facilities, it is often because of accessibility. Whereas delay number three is due to poor quality care. So you see that delay number one is the most important, but it has all of the elements of care that need to be improved, health system building that need to be improved to reduce maternal mortality. Next slide. So here's it. Again, I'm showing this again that shows that delay number one, all of those elements, sociocultural factors, accessibility of factors, and quality of care relate to the decision of a woman to seek care. Whereas delay number two simply talks about accessibility of facilities. Whereas delay number three is more about the quality of care. So I will talk about the type of experiments we conducted that will further illustrate all of this later on. So our hypothesis, distinguished gentlemen, is that if we can reduce type 1 delays, then we can reduce maternal mortality, especially if the demand and supply side factors are simultaneously addressed. Then we can bring women to orthodox evidence-based services quickly and rapidly, rather than allow them to access untested traditional methods of delivery. In Nigeria, only about 33% of women who are delivering, only 30% receive care or are delivered by health professionals. By contrast, in Sweden, where maternal mortality rate is almost zero, almost 100% of women receive care when they are delivering. Our approach was to conduct a series of studies to determine why type 1 delays occur, and then to test a series of multifaceted interventions to reduce type 1 delays. And our studies and intervention focused on the most at-risk poor women in rural areas, because that's where the vulnerability exists, who use primary care facility for antenatal, intrapartum, and early postnatal. Often they don't have secondary, they don't have tertiary care. So this was where we started the work, generating evidence for action. Between 2019 and 2022, work in collaboration with University of Ottawa, the African Center of Excellence in Reproductive Health Innovation, West African Health Organization. We also have Nigerian Federal Ministry of Health, the Edo State Primary Care Development Agency, and 12 local communities with support from the IDRC, conducted a series of mixed studies followed by intervention research to find out why rural women do not use available primary care facilities for skilled pregnancies and why they resort to traditional methods rather than skilled pregnancy care methods. And I'm happy Professor Loretta Tiomo, I saw her on this program. She's one of those who led this program, who was on the technical. And these are some of our teams in work that actually conducted the study. So this was the design of the study. We had informative research consisting of interviews, focus group discussions, survey of females, primary care audit, then followed by the development of intervention, a process whereby we engaged all stakeholders, community leaders, to plan and develop intervention. Initially, we wanted to use some form of more scientific methods, the mind control trial, but later we opted for a quasi experimental study design. It consisted of a pre-test qualities, examination of the indicators, followed by multi-faceted interventions and implementation of these interventions, and then continuous monitoring and implementation. in 12 communities. And at the end, we did a post-implementation survey, compared the beginning indicators with the end indicators. So this is it, the summary of the project: methods, formative research, intervention, co-creation, and implementation, information, which includes set of staff training. These are the components of the intervention: information and risk communication, referral to test for life, which I discussed more in detail, staff training, community engagement, civil engagement and participation, co-creation with communities. This was what I did, and we published almost 20 papers from this single intervention based on all of the things that we did. And I'm thanking local decision making, etc. So some of the results we got published, for example, this one was published in pregnancy, BMC, pregnancy and childbirth, showing that only 47% of the pregnant women in the 12 communities delivered in the available primary care facilities. And we discovered that our interesting finding was that, the higher the maternal education, the lower the chances that women would use primary care services in rural populations. And we found out that this was due to the fact that more educated women perceived that primary care facilities had low quality, that the quality of care was not good enough for them to attend. So they opted to go to surrounding secondary care facilities. But for those who used primary care facilities, these were more likely to be women who had low level education. Then we also found that women who had low autonomy were less likely to use primary care, as well as those who were unemployed or who were poor. So for that, we did another study, so many of them showing why women use traditional rather than orthodox practices, orthodox maternal care practices. And this was published in BMC again, pregnancy and childbirth. And this was a qualitative study which showed that women identify poor rules and difficulty with transportation as a major reason why they do not use orthodox services. They believe so strongly that they lived in the same community with the traditional practitioners, and it was easier to get to them, and that their services were cheaper. So they identified poor rules, difficulty with transportation, high cost of orthodox services, and the perception relating to the fact that the quality of care in primary centers were poor, was not good enough. So they decided not to use. And also some of the facilities did not have equipment and were never opened. So these were what we got from the student women at the form of formative research. So we then did a series of workshops to using the results of the formative research to design interventions. And at the end of it, we decided that it was not going to be easy to use one single intervention to address the challenges that were raised at the formative research. So we chose, what I call, mixed methods or mixed multifaceted approach, consisting of community health talks, community health fund, which we developed, which was also managed by the community itself. And it included contribution from the diaspora, people who lived from outside the community, who are present, who are living in urban centers. We also had community health insurance, and we trained and retrained the health facility, and also re-equipped the health facilities. And then finally, because of the difficulties that women had, they said they had, we asked the question, is it not possible? Don't they have taxi owners that they can immediately call when they have problems? The answer was yes. So we identified the transport owners who resided in villages. And then the concept of how do you get these transport owners linked up to the women when they have complications. So it was at that point that the idea of mobile test for life came up using mobile phone. I would just ask this question, ask Dr. Loretta, do you know somebody who can help us to think of an app that would include testing a need for a transport by a woman to that particular to the server, and from there the transport owner will meet the woman? I said yes. She said she will look at, and later on she identified a young man in Lagos who said he could do it, and we engaged him, we discussed with him, and I was so excited when he was able to come up with this idea and develop it. So WAC is a leading non-governmental organization, currently implements the Test for Life app in its location here in Benin, in collaboration with the UNFPA, the African Center of Excellence in Reproductive Innovation, the Federal Ministry of Health, the West African Health Organization, and several community stakeholders. It is a mobile phone technology that employs a telemedicine approach using unstructured supplementary device service data to allow users to report maternal health and other complications to a central server located in work offices. So, although it was first designed for 12 project communities, I'm pleased to say that it's now been extended and scaled up through the efforts of the United Nations Fund for Population activities. They were quite excited and they've helped up over the years and are still helping us to extend it to 12 Nigerian states. So this is how it works. On the left, you see a woman with a mobile phone, and she has a complication. So she has a code with which she tests the phone with the code to a server saying that she has a complication. And the server will then immediately contact a mobile, you see the ambulance on the right, transport system. And also, at the same time, relay the information of the complication that the woman has to a healthcare facility, primary healthcare facility. And you can see that the transport system, the taxi driver, will then go to the woman, responds immediately to pick the woman. And he arrives, brings the woman to the healthcare facility. This is a rough drawing of actually what happens. The woman has a code, and that code is being advertised for all pregnant women. And that code gets to the server, and the server immediately sends a message to the local driver in the vicinity, a local taxi driver in the vicinity who has been pre-recorded and pre-registered. And the driver will immediately meet the woman in her home, pick her up, bring her to the primary health care center, and then immediate action will be taken. And this takes place within a short. The important issue to note is that women often have signs of pregnancy and complications at night. Nobody knows why that is so. I think it may relate to some hormones and all that, but you can notice most women who deliver or who go into labor for the first time tend to labor in the night. And so this app becomes very useful because usually in the night, if a woman's husband doesn't have a car, she doesn't have a car, then the difficulty of bringing the woman to court. These taxis respond at any point in time, even at night, especially in rural communities where it is often safe to do so. So this is the description of the app, which we call Test for Life, because the Test for Life is we are testing for the life of the woman to ensure that she and her baby survive. So this is what, and this is the office. You can see the young lady there who manages the computer. There's a back end where all the information comes to, where those things are processed, and you look at the batteries behind, which are the batteries to ensure 24-hour supply of electricity. I want to thank the West African Health Organization, the Federal Ministry of Health of Nigeria, and the United Nations Fund for Population activities that funded this from then till now. They just extended us some payments to be able to ensure that these services continue to be operational. So the concept of the test for life will be proven, and we have published that test of concept, testing for life, a mobile phone application to connect pregnant women with pregnancy and emergency application. It was published in BMC Pregnancy and Childbirth in March 2023. Over a period of 18 months, 56 out of 1,020 women we tested the device in that local government area, in those 12 local government areas, requesting transportation. Obviously, not every woman will request transportation. Some of them could easily not request it because the services may be closer to them. Out of these 56, 51 were successfully transported from one to the other. About five were not transported. Maybe the vehicles were not available at the time or something. And then 46 were successfully treated at the primary health center, while 5 were referred to secondary care facilities. At that time, no single maternal death occurred in the communities. So we tried to find out what are the enablers of men's health. We did another study, and again, the paper is there, published in Dialogues in Health, which showed that some of the enablers of that system included positive community participation, participant understanding of the app, so you have to do a lot about that, and then confidence that it is effective, whereas the barriers were limited resources and then clash with the value systems. So in 2003, we conducted a further evaluation, and we found that a total of 3,403 messages related to prepared challenges were received in the server. Information was then obtained from the back end. We identified the locations where these challenges came from, and conducted telephone interviews with 21 women who tested the course, 15 CSO representatives, and 16 health facility managers to identify how the issues were. And the reviews are analyzed. We have since published that, and we presented that paper at the symposium, Harvard University Symposium on Digital Health, which took place in 2023. And actually, the paper there has been accepted and to be published later this month, early in September. Over 28 months, 3,486 reports were received at the back end. And nearly 35% were GBV, gender-based violence, meaning that apart from using it for maternal health protection, they are now using it for other reproductive challenges. And maternal health was a major issue. So the results show that majority of the users acknowledge usefulness of the app in enabling them to report cases of maternal problems and gender in a confidential and safe manner. And they called it a life-saving line for victims. And so, just to end, management, they received a response in form of a call, but some of them said they did not receive any response after they sent the code. And narrating how the cases were managed, the CSO or health providers followed the standard protocols that we trained them to use in handling pregnancy complications, and then referred cases to when they could not handle. So, therefore, to conclude, the main recommendation for scaling this, because it's very important, if there are no, we have been a chance over the last years, this app addresses the problem of the type 1 delay and also type 2 delay. Awareness creation about the app, training of health providers and CSOs to use the app, provision of more information and communication materials on the app, and then close monitoring of the implementers, as well as increased funding and partnership with government. I believe very strongly that government partnership is the only way we can really scale up this device innovation throughout the entire country. Conclusion, ladies and gentlemen, I hereby conclude that a mobile phone device can be effective in the reporting of pregnancy and reproductive health challenges, and to bringing women to evidence-based services, reducing delay, ensuring that women use evidence-based services rather than unorthodox traditional methods. And the results of our studies suggest that digital technologies can improve both the reporting of and responses to maternal health complications and potentially other scientific health problems in our low resource setting. Nigeria rate today, use of mobile phone is almost going to about 80%. So if you cannot use it, then it's evidence has shown in literature that even your relatives, your husband, or your daughters, your others can help you in getting information and related information in the mobile phone. However, the introduction of digital technology is still not the only solution. It's still not the only solution. Other shortcomings, particularly in the ecosystem and social-cultural and cultural beliefs, also need to be addressed. Acknowledge International Development Research Center, the West African Health Organization, Nigeria's Federal Ministry of Health, UNFP, Nigerian Office, Ottawa University, African Center of Excellence in Reproductive Health and Innovation, and the Takemi Program International Health at Harvard University. These are some of the publications which you can have, and I will send it to you more. Thank you very much, ladies and gentlemen.
Thank you very much, Prof, for such an insightful presentation. You did such a good job of really laying out the scene of the land and emphasizing where the problem of maternal mortality in your setting really is. And we're also glad that you have considered what it needs to happen for this kind of innovation to be scaled up. Do you think that it could work in a different country with a similar setting?
Yeah, absolutely. It will work. It will work in any country in Africa because the elements are very simple and they are easily transferable. Countries with similar problems, similar challenges can easily use it. And actually, the interest of the West African Health Organization was derived from the fact that it's going to be used in other parts of West Africa. It can be used in other parts of West Africa. So it's a good recommendation.
That's amazing. Prof, we would have loved to engage with you longer. Unfortunately, we have reached the end of our allocated time for this afternoon's engagement, but the conversation isn't over. The whole point of the platform, of the Dina Health platform, is that such collaborations, conversations continue, and that we continue to learn from the expertise of professors like Prof. Friday. Let me not butcher your surname. Thank you all very much for joining us. Please do download the app that was shown to us earlier today, and this whole platform of DIMA is about collaboration. The creators of DIMA Health really want to hear from you and how we can improve this and collaborate and share lessons learned, and so that we could use and harness mobile technology to really tackle the issue of maternal mortality in Africa. Prof, thank you very much. Have a good afternoon.
Thank you. Thank you.